Inflammation, CSIR-NET JRF Life Sciences Lecture Introduction. Inflammation is a complex biological response of vascular tissues to harmful stimuli, such as pathogens, damaged cells, or irritants. It is a protective mechanism aimed at removing the injurious stimuli and initiating the healing process. However, if the inflammatory response is not regulated properly, it can lead to chronic inflammation and contribute to various diseases, including autoimmune disorders, cardiovascular diseases, cancer, and neurodegenerative conditions. Inflammation can be classified into two main types. Acute inflammation, the early, short-term response to injury or infection. Chronic inflammation, long-lasting inflammation, often due to unresolved acute inflammation or ongoing immune system activation. Phases of inflammation, initiation phase. This phase begins with the recognition of the harmful stimulus, e.g., infection, injury by pattern recognition receptors (PRRs) on immune cells, particularly macrophages, dendritic cells, and neutrophils. PRRs recognize pathogen-associated molecular patterns (PAMPs) or damage-associated molecular patterns (DAMPs). These are recognized through toll-like receptors (TLRs) or other PRRs on the surface of immune cells. Vascular phase. Once inflammation is triggered, vasodilation occurs, increasing blood flow to the affected tissue. The permeability of blood vessels also increases, allowing the extravasation leakage of proteins in immune cells like neutrophils, monocytes into the inflamed tissue. This leads to the classic signs of inflammation. Redness, erythema due to increased blood flow. Heat pallor as a result of the increased blood flow. Swelling, edema due to the accumulation of fluid in immune cells. Pain, dolor due to the release of inflammatory mediators and pressure on the surrounding tissues. Cellular phase. In this phase, immune cells, especially neutrophils and macrophages, infiltrate the affected tissue. Chemotaxis is the process by which these cells are attracted to the site of injury or infection by signaling molecules such as chemokines, e.g., IL-8. Phagocytosis occurs, where immune cells engulf and degrade pathogens, dead cells, and other debris. Resolution phase. Once the harmful stimuli are cleared, inflammation should resolve to restore tissue homeostasis. Anti-inflammatory cytokines such as IL-10 and TGF-beta play a crucial role in terminating inflammation and promoting tissue repair. Failure in the resolution phase can lead to chronic inflammation. Mediators of inflammation, vasoactive amines. Histamine and serotonin are released by mast cells, basophils, and platelets. These mediate vasodilation and increase vascular permeability. Prostaglandins and leukotrienes. Derived from arachidonic acid through the action of cyclooxygenase COX enzymes prostaglandins and lipoxygenase LOX enzymes leukotrienes. Prostaglandins cause vasodilation, fever, and pain. Leukotrienes promote chemotaxis and increase vascular permeability. Cytokines. Tumor necrosis factor alpha TNF-alpha and interleukin-1. Derived from arachidonic acid through the action of cyclooxygenase COX enzymes prostaglandins and lipoxygenase LOX enzymes leukotrienes. Prostaglandins cause vasodilation, fever, and pain. Leukotrienes promote chemotaxis and increase vascular permeability. Cytokines. Tumor necrosis factor alpha TNF-alpha and interleukin-1 IL-1 are pro-inflammatory cytokines that increase vascular permeability, promote leukocyte adhesion to the endothelium, and stimulate the release of other inflammatory mediators. Interleukin-6 IL-6 is another important cytokine that helps in acute phase response and promotes fever. Chemokines. These are small signaling molecules, e.g., IL-8, MCP1, that attract immune cells to the site of inflammation. Complement system. The complement system is activated during inflammation and helps in opsonization of pathogens, chemotaxis, and lysis of pathogens. Complement proteins such as C3a and C5a are potent anaphylotoxins that increase vascular permeability and attract immune cells to the site of infection. Reactive oxygen species, ROS, and nitric oxide, NO. Produced by immune cells like neutrophils and macrophages, ROS and NO are important for pathogen killing. However, excessive production of these molecules can cause tissue damage and contribute to chronic inflammation. Types of inflammation, acute inflammation. Characteristics, rapid onset, short duration, primarily involving neutrophils. Triggers, infections, physical injury, burns, chemical irritants. Resolution, if successful, acute inflammation resolves with the restoration of tissue function and healing. Chronic inflammation. Characteristics, long-lasting, involving macrophages, T cells, and fibroblasts. It is associated with tissue damage and repair. Triggers, persistent infections, autoimmune diseases, prolonged exposure to irritants, and chronic stress. Consequences, tissue remodeling, fibrosis, and potential for organ dysfunction, e.g., rheumatoid arthritis, inflammatory bowel disease, IBD, asthma. Regulation of inflammation. Inflammation is tightly regulated to avoid excessive tissue damage. Key regulatory mechanisms include anti-inflammatory cytokines. IL-10 and TGF-beta are major anti-inflammatory cytokines that suppress the expression of pro-inflammatory cytokines and promote the resolution of inflammation. Resolving factors. Specialized pro-resolving mediators such as lipoxins, resolvins, and protectins are produced during inflammation and help in the resolution phase by promoting the clearance of immune cells and tissue repair. Regulatory T cells, TREGs. TREGs suppress excessive immune responses, preventing chronic inflammation and autoimmunity. Apoptosis of activated immune cells. Programmed cell death. Apoptosis of activated immune cells, especially neutrophils, is an essential mechanism to resolve inflammation and avoid chronic inflammation. Clinical relevance of inflammation, acute inflammatory diseases. Conditions such as appendicitis, pneumonia, and infections often involve acute inflammation. Inflammatory mediators play a significant role in the symptoms of acute inflammation, such as fever, redness, and pain. Chronic inflammatory diseases. Chronic inflammation is a major factor in diseases such as rheumatoid arthritis, atherosclerosis, and inflammatory bowel disease, IBD. Persistent inflammation contributes to tissue damage, fibrosis, and the development of cancer, e.g., colorectal cancer linked to chronic IBD. Inflammation and cancer. Chronic inflammation is associated with an increased risk of tumor development. For instance, chronic viral infections or chronic tissue injury can lead to mutagenesis and carcinogenesis. CSIR-NET previous year questions. 1. CSIR-NET June 2020. Which of the following cytokines is most associated with the acute phase response during inflammation? A TNF-alpha. BL6-CIL1-DIFN gamma answer. BIL6. 2. CSIR-NET DEC 2021. What is the primary function of the complement system in inflammation? A stimulating the production of antibodies, B enhancing pathogen phagocytosis and lysis, C inducing fever. D recruiting T cells to the site of infection answer. B enhancing pathogen phagocytosis and lysis. Conclusion. Inflammation is a vital defense mechanism that aids in the removal of pathogens and tissue repair. However, when poorly regulated, inflammation can lead to chronic diseases, tissue damage, and complications such as cancer. Understanding the mediators, phases, and regulation of inflammation is essential for developing therapeutic strategies to modulate inflammatory responses in diseases such as autoimmune disorders, cardiovascular diseases, and infections. Feel free to ask for more clarification or additional topics. You said, hypersensitivity. ChatGPT said. Hypersensitivity, CSIR-NET JRF Life Sciences Lecture Introduction. Hypersensitivity refers to an exaggerated or inappropriate immune response to harmless environmental antigens, allergens, or self-antigens. These reactions result in tissue damage and clinical symptoms that range from mild to life-threatening. Hypersensitivity reactions are classified into 4 main types, type 1 to type 4, based on the immune mechanism involved. Classification of hypersensitivity reactions. Type 1 hypersensitivity, immediate or IgE-mediated hypersensitivity. Mediators, IgE antibodies, mast cells, basophils, and histamine. Mechanism. In this type of reaction, the immune system produces IgE antibodies in response to exposure to an allergen, e.g., pollen, dust mites, peanuts. Upon subsequent exposure, the allergen binds to IgE on mast cells and basophils, leading to the release of histamine and other mediators, causing symptoms of allergic reactions. Clinical manifestations. Symptoms occur rapidly within minutes of exposure and include allergic rhinitis, hay fever, asthma, urticaria, hives, anaphylaxis, severe, systemic allergic reaction that can lead to shock and death. Example, peanut allergy, bee stings, and seasonal allergic rhinitis. Key points. The reaction is fast, occurring within minutes of exposure. Histamine and other mediators cause vasodilation, increased vascular permeability, and smooth muscle contraction. Type 2 hypersensitivity, cytotoxic hypersensitivity. Mediators, IgE and IgM antibodies, complement system, phagocytes. Mechanism. In type 2 hypersensitivity, the immune system mistakenly targets host cells that are recognized as foreign due to the presence of an antigen, e.g., blood group antigens, drugs. IgE or IgM antibodies bind to the antigen on the cell surface, leading to complement activation, phagocytosis, or cell lysis. Clinical manifestations. Conditions include hemolytic anemia, destruction of red blood cells, blood transfusion reactions, mismatch of blood groups, Goodpasture syndrome, autoimmune disease affecting the kidneys and lungs. Example, rhesus incompatibility in newborns, hemolytic disease of the newborn, autoimmune hemolytic anemia. Key points. IgE or IgM antibodies mediate cell damage. Complement activation and phagocytosis lead to cell destruction. Type 3 hypersensitivity, immune complex mediated hypersensitivity. Mediators, immune complexes, antigen antibody, complement system, neutrophils. Mechanism. Type 3 reactions are characterized by the formation of immune complexes, antigen antibody complexes, that deposit in tissues and activate the complement system. These complexes induce an inflammatory response, leading to tissue damage. Clinical manifestations. Disorders include systemic lupus erythematosus, SLE, rheumatoid arthritis, RA, serum sickness, a reaction to non-human serum proteins. Artus reaction, localized immune complex reaction at the site of antigen injection. Example, lupus nephritis, kidney damage due to immune complexes, post-streptococcal glomerulonephritis. Key points. Immune complexes deposit in tissues, e.g., kidneys, skin, joints. The complement system is activated, leading to inflammation and tissue damage. Type 4 hypersensitivity, delayed type hypersensitivity, or cell-mediated hypersensitivity. Mediators, T lymphocytes, macrophages. Type 3 hypersensitivity, immune complex mediated hypersensitivity. Mediators, immune complexes, antigen antibody, complement system, neutrophils. Mechanism. Type 3 reactions are characterized by the formation of immune complexes, antigen antibody complexes, that deposit in tissues and activate the complement system. These complexes induce an inflammatory response, leading to tissue damage. Clinical manifestations. Disorders include systemic lupus erythematosus, SLE, rheumatoid arthritis, RA, serum sickness, a reaction to non-human serum proteins. Artus reaction, localized immune complex reaction at the site of antigen injection. Example, lupus nephritis, kidney damage due to immune complexes, post-streptococcal glomerulonephritis. Key points. Immune complexes deposit in tissues, e.g., kidneys, skin, joints. The complement system is activated, leading to inflammation and tissue damage. Type 4 hypersensitivity, delayed type hypersensitivity, or cell-mediated hypersensitivity. Mediators, T lymphocytes, macrophages. Mechanism. Unlike other types, type 4 hypersensitivity is mechanism. In type 2 hypersensitivity, the immune system mistakenly targets host cells that are recognized as foreign due to the presence of an antigen, e.g., blood group antigens, drugs. IgE or IgM antibodies bind to the antigen on the cell surface, leading to complement activation, phagocytosis, or cell lysis. Clinical manifestations. Conditions include hemolytic anemia, destruction of red blood cells, blood transfusion reactions, mismatch of blood groups, Goodpasture syndrome, autoimmune disease affecting the kidneys and lungs. Example, rhesus incompatibility in newborns, hemolytic disease of the newborn, autoimmune hemolytic anemia. Key points. IgE or IgM antibodies mediate cell damage. Complement activation and phagocytosis lead to cell destruction. Type 3 hypersensitivity, immune complex mediated hypersensitivity. Mediators, immune complexes, antigen antibody, complement system, neutrophils. Mechanism. Type 3 reactions are characterized by the formation of immune complexes, antigen antibody complexes, that deposit in tissues and activate the complement system. These complexes induce an inflammatory response, leading to tissue damage. Clinical manifestations. Disorders include systemic lupus erythematosus, SLE, rheumatoid arthritis, RA, Serum sickness, a reaction to non-human serum proteins. Artus reaction, localized immune complex reaction at the site of antigen injection. Example, lupus nephritis, kidney damage due to immune complexes post-streptococcal glomerulonephritis. Key points. Immune complexes deposit in tissues e.g., kidneys, skin, joints. The complement system is activated, leading to inflammation and tissue damage. Type 4 hypersensitivity, delayed type hypersensitivity or cell-mediated hypersensitivity. Mediators, T lymphocytes, macrophages. Mediators, T lymphocytes, macrophages. Mechanism, unlike other types, type 4 hypersensitivity is mediated by type 3 hypersensitivity, immune complex mediated hypersensitivity. Mediators, immune complexes, antigen antibody complement system, neutrophils. Mechanism, type 3 reactions are characterized by the formation of immune complexes, antigen antibody complexes that deposit in tissues and activate the complement system. These complexes induce an inflammatory response, leading to tissue damage. Clinical manifestations, disorders include systemic lupus erythematosus, SLE, rheumatoid arthritis, RA, serum sickness, a reaction to non-human serum proteins. Artus reaction, localized immune complex reaction at the site of antigen injection. Example, lupus nephritis, kidney damage due to immune complexes post-streptococcal glomerulonephritis. Key points. Immune complexes deposit in tissues e.g., kidneys, skin, joints. The complement system is activated, leading to inflammation and tissue damage. Type 4 hypersensitivity, delayed type hypersensitivity or cell-mediated hypersensitivity. Mediators, T lymphocytes, macrophages. Mechanism, unlike other types, type 4 hypersensitivity is mediated by T cells, specifically CD4 plus T helper cells and CD8 plus cytotoxic T cells rather than antibodies. Upon exposure to an antigen, T cells become activated and release cytokines, which recruit macrophages to the site of antigen exposure. This results in inflammation and tissue damage. Clinical manifestations, conditions include contact dermatitis e.g., poison ivy, nickel allergy, tuberculosis TB, skin test, Mantoux test, graft rejection when the immune system attacks transplanted tissue. Example, poison ivy rash, tuberculin skin test testing for TB exposure. Key points. T cells mediate the immune response. Macrophage activation leads to chronic inflammation and tissue damage. Mechanisms of hypersensitivity, antibodies in type 1, 2, and 3 hypersensitivity. In type 1, the primary mediator is IgE, which binds to mast cells and basophils, causing degranulation and release of histamine. Type 2 involves IgG and IgM antibodies, which bind to cell surface antigens and activate the complement system or recruit phagocytes to destroy the cells. Type 3 reactions are mediated by the formation of immune complexes, which deposit in tissues, activate the complement system, and recruit neutrophils, causing tissue damage. T cells in type 4 hypersensitivity. In type 4, CD4 plus T helper cells recognize the antigen presented by antigen-presenting cells, APCs, and release cytokines, which activate macrophages and recruit more immune cells to the site of infection, resulting in delayed type hypersensitivity. Clinical examples, type 1 hypersensitivity. Allergic asthma, characterized by IgE-mediated mast cell activation leading to bronchoconstriction, mucus production, and airway inflammation. Type 2 hypersensitivity. Hemolytic disease of the newborn occurs when Rh-negative mothers produce antibodies against Rh-positive fetal blood cells, leading to the destruction of red blood cells. Type 3 hypersensitivity. Systemic lupus erythematosus, SLE, immune complexes form and deposit in various tissues, leading to widespread inflammation, particularly in the kidneys. Type 4 hypersensitivity. Contact dermatitis, caused by T-cell mediated immune response to allergens like poison ivy, resulting in localized skin inflammation. Clinical examples, type 1 hypersensitivity. Allergic asthma, characterized by IgE-mediated mast cell activation leading to bronchoconstriction, mucus production, and airway inflammation. Type 2 hypersensitivity. Hemolytic disease of the newborn occurs when Rh-negative mothers produce antibodies against Rh-positive fetal blood cells, leading to the destruction of red blood cells. Type 3 hypersensitivity. Systemic lupus erythematosus, SLE, immune complexes form and deposit in various tissues, leading to widespread inflammation, particularly in the kidneys. Type 4 hypersensitivity. Contact dermatitis, caused by T-cell mediated immune response to allergens like poison ivy, resulting in localized skin inflammation. Regulation and treatment, treatment of hypersensitivity reactions. Type 1, antihistamines, corticosteroids, and epinephrine in severe reactions, e.g., anaphylaxis. Type 2, immunosuppressive drugs such as corticosteroids, plasmapheresis, and intravenous immunoglobulin, IVIG. Type 3, corticosteroids and immunosuppressive drugs to reduce inflammation. Type 4, topical corticosteroids for localized reactions, e.g., contact dermatitis or systemic immunosuppressive drugs for severe cases. Regulation. Proper regulation of the immune response is crucial in preventing hypersensitivity. Factors such as immune tolerance, regulatory T cells, TREGs, and immunosuppressive cytokines, e.g., IL-10, TGF-beta play a role in limiting hypersensitivity reactions. CSIR Net previous year questions. 1. CSIR Net June 2019, which of the following hypersensitivity reactions is primarily mediated by IgE antibodies? A type 1, B type 2. C type 3, D type 4 answer, a type 1. 2. CSIR Net Deck 2020, in type 4 hypersensitivity, the immune response is primarily mediated by A antibodies, B T lymphocytes. Sequence system D mast cells answer, B T lymphocytes. Conclusion. Hypersensitivity reactions represent an exaggerated or inappropriate immune response to non-pathogenic stimuli, leading to tissue damage. The 4 types I to IV differ in the immune mechanisms involved, including antibody-mediated responses types I, 2, and 3, and cell-mediated responses type 4. Proper understanding of these mechanisms helps in diagnosing and managing hypersensitivity-related diseases, including allergies, autoimmune diseases, and chronic inflammatory disorders. Feel free to ask for further clarifications or additional topics. You said, autoimmunity, ChatGPT said. Autoimmunity, CSIR Net JRF Life Sciences Lecture Introduction. Autoimmunity refers to a condition in which the body's immune system mistakenly targets its own healthy cells, tissues, or organs, leading to immune-mediated damage. In normal immunity, the immune system distinguishes between self and non-self. However, in autoimmune diseases, this tolerance is lost, and the immune system produces antibodies, autoantibodies, or activates T cells that attack the body's own cells, causing inflammation and tissue destruction. Autoimmune diseases can be systemic, affecting multiple organs, or organ-specific, affecting a single organ. The underlying mechanisms of autoimmunity involve complex interactions between genetic, environmental, and immunological factors. Mechanisms of autoimmunity: loss of self-tolerance. Self-tolerance is the ability of the immune system to recognize and ignore self-antigens. Loss of tolerance leads to autoimmune responses. This can occur due failure of central tolerance in the thymus or bone marrow, where self-reactive T or B cells are eliminated. Failure of peripheral tolerance in tissues outside primary lymphoid organs, where regulatory T cells, TREGs, or immune checkpoints such as CTLA-4 or PD-1 normally prevent autoreactive immune responses. Molecular mimicry. Molecular mimicry occurs when foreign antigens, typically from pathogens, share structural similarities with self-antigens. The immune system may mistakenly target both the pathogen and the body's tissues due to this similarity. Example: rheumatic fever, where antibodies against Streptococcus bacteria cross-react with cardiac tissue due to similarities in molecular structure. Genetic factors. Certain genetic predispositions increase susceptibility to autoimmune diseases. Specific MHC alleles, especially MHC class II molecules, are often associated with an increased risk. Example: HLA-DR3 and HLA-DR4 alleles are linked to diseases like systemic lupus erythematosus (SLE) and rheumatoid arthritis (RA), respectively. Environmental factors. Environmental triggers such as infections, UV radiation, and chemicals can activate the immune system, leading to the onset or exacerbation of autoimmune diseases. Example: Epstein-Barr virus (EBV) infection has been linked to the development of autoimmune conditions like multiple sclerosis (MS) and SLE. Types of autoimmune diseases: systemic autoimmune diseases. These diseases affect multiple organs and tissues throughout the body. Systemic lupus erythematosus (SLE) characterized by the production of autoantibodies against nuclear antigens, e.g., anti-dsDNA antibodies. It affects the skin, kidneys, joints, and other organs. Rheumatoid arthritis (RA) inflammation of the synovial joints, caused by autoantibodies against cyclic citrullonated peptides (CCPs), leading to chronic joint destruction. Sjogren's syndrome affects exocrine glands such as salivary and lacrimal glands, leading to dry mouth and eyes due to autoantibodies targeting RO and LA antigens. Organ-specific autoimmune diseases. These diseases affect specific organs or tissues. Type 1 diabetes mellitus T1DM T cells attack the insulin-producing beta cells of the pancreas, leading to insulin deficiency. Multiple sclerosis MS T cells attack the myelin sheath of nerve fibers in the central nervous system, CNS, causing demyelination and neurological deficits. Hashimoto's thyroiditis. Autoantibodies attack the thyroid gland, leading to hypothyroidism. Graves' disease. Autoantibodies activate the thyroid-stimulating hormone receptor, TSHR, causing hyperthyroidism. Pathophysiology of autoimmunity. Autoantibody production. In autoimmune diseases, the immune system produces autoantibodies that recognize and bind to self-antigens. These autoantibodies may directly cause tissue damage or form immune complexes that deposit in tissues, activating the complement system and recruiting inflammatory cells. Example: in SLE, anti-dsDNA antibodies form immune complexes that deposit in the kidneys, causing lupus nephritis. T-cell-mediated responses. CD4 plus T helper cells or CD8 plus cytotoxic T cells may become activated against self-antigens, leading to tissue damage. Example: in type 1 diabetes, CD8 plus T cells attack and destroy the insulin-producing cells in the pancreas. Chronic inflammation. In most autoimmune diseases, chronic inflammation occurs as a result of ongoing immune responses against self-antigens, leading to the recruitment of macrophages and neutrophils, as well as the production of inflammatory cytokines like TNF-alpha, IL-6, and IL-1. Clinical features and diagnosis. Clinical features. Symptoms vary depending on the organ or tissue affected but often include fatigue, joint pain and swelling, especially in RA, skin rashes notably in SLE, dry mouth and eyes in Sjogren's syndrome, neurological symptoms in MS. Diagnostic tests. Autoantibody testing. Detection of specific autoantibodies, e.g., anti-dsDNA, anti-CCP, is crucial for diagnosing autoimmune diseases. Complement levels. Low levels of C3 and C4 can indicate immune complex-mediated diseases like SLE. Tissue biopsy. In cases of suspected rheumatoid arthritis or SLE, a biopsy may be performed to assess inflammation and tissue damage. Example: in SLE, the presence of anti-dsDNA antibodies and decreased complement levels are indicative of active disease. Treatment of autoimmune diseases. Immunosuppressive therapy. Corticosteroids are commonly used to reduce inflammation in autoimmune diseases. Methotrexate, azathioprine, and cyclophosphamide are used to suppress the immune response in diseases like RA and SLE. Biologic therapy. Targeted therapies, including TNF inhibitors, e.g., etanercept, infliximab, and B-cell depletion agents, e.g., rituximab, are used in diseases like RA and SLE. Plasmapheresis. A procedure in which autoantibodies and immune complexes are removed from the blood to reduce disease activity. Gene therapy and regulatory T-cell expansion. Treatments may include expanding regulatory T cells, TREGs, to restore immune tolerance and prevent autoimmunity. CSIR-NET previous year questions. 1. CSIR-NET June 2018, which of the following is the most commonly associated HLA allele with the development of rheumatoid arthritis? A HLA-B27B, HLA-DR4. CHLA-DR3, DHLA-DQ2. Answer: BHLA-DR4. 2. CSIR-NET DEC 2020, autoimmunity in diseases like SLE is mediated which of the following? ATH2 response, BTH1 response. C autoantibodies, D NK cells. Answer: C autoantibodies. Conclusion. Autoimmunity occurs when the immune system fails to recognize self-antigens as harmless, resulting in tissue damage. It involves a complex interplay of genetic, environmental, and immunological factors. Understanding the mechanisms behind autoimmunity helps in diagnosing and developing targeted therapies for autoimmune diseases, offering better management and improved outcomes for patients. Let me know if you need further clarifications or additional topics. You said. Immune response during bacterial tuberculosis. ChatGPT said. Immune response during bacterial infections. Tuberculosis. CSIR-NET JRF Life Sciences Lecture Introduction. Tuberculosis (TB) is a bacterial infection caused by Mycobacterium tuberculosis, primarily affecting the lungs but can also impact other parts of the body. The immune response to M. tuberculosis is complex and involves both innate and adaptive immunity. TB is a chronic infectious disease, and the immune system's ability to control or eliminate the bacteria determines the clinical outcome, ranging from asymptomatic infection, latent TB, to active disease. The immune response during tuberculosis infection can be divided into innate and adaptive immunity, both of which play crucial roles in controlling the infection. However, M. tuberculosis has evolved mechanisms to evade the immune system, contributing to chronic infection and the development of drug resistance. Innate immune response to tuberculosis, entry and recognition of pathogen. M. tuberculosis is primarily transmitted through respiratory droplets and is inhaled into the lungs, where it is engulfed by alveolar macrophages, the first line of defense. The bacteria are recognized by pattern recognition receptors, PR. The bacteria are recognized by pattern recognition receptors, PRRs, such as toll-like receptors, TLRs, on the surface of macrophages. TLR2 and TLR4 are the most important receptors recognizing mycobacterial lipids and other components. Once internalized, M. tuberculosis can survive within macrophages by preventing the fusion of the phagosome, which contains the bacteria, with the lysosome, creating a favorable environment for its replication. Activation of the innate immune. Upon recognition, macrophages secrete pro-inflammatory cytokines such as TNF-alpha, IL-1, and IL-12 that recruit other immune cells to the site of infection. Neutrophils are also recruited to the site of infection, but their role in tuberculosis is controversial. They contribute to the inflammatory response but are less effective at killing the bacteria compared to macrophages. Formation of the granuloma. A hallmark of the immune response to tuberculosis is the formation of a granuloma, a structure formed by macrophages, T lymphocytes, and other immune cells. The granuloma serves to contain the infection by walling off the bacteria. Caseous necrosis may occur in the center of the granuloma, which is often seen in active TB and indicates an area of tissue death due to persistent inflammation and bacterial persistence. Adaptive immune response to tuberculosis, T helper cell Th1 activation. The key adaptive immune response in tuberculosis is mediated by T lymphocytes, particularly CD4+ T cells. Upon activation, macrophages present mycobacterial antigens to naive T cells through MHC class II molecules. The interaction between antigen-presenting cells APCs and CD4+ T cells leads to the activation of a Th1 response, which is essential for the control of M. tuberculosis. Th1 cells secrete IFN gamma, a cytokine crucial for activating macrophages to kill the bacteria. Macrophage activation by IFN gamma. IFN gamma enhances the microbicidal activity of macrophages, promoting the production of reactive oxygen species, ROS, and nitric oxide NO to kill the bacteria. CD8+ cytotoxic T cells also play a role in killing infected cells directly by recognizing infected cells via MHC class I molecules. These cytotoxic T cells can target infected cells for apoptosis. Formation of a protective granuloma. The granuloma becomes a site of intense immune activity. CD4+ T cells, macrophages, and other immune cells form the structure, which serves to contain the bacteria and limit its spread. However, if the immune response is insufficient or dysregulated, the granuloma may not be able to effectively control the bacteria, leading to active TB. Immune evasion by mycobacterium tuberculosis, inhibition of phagosome-lysosome fusion. M. tuberculosis can survive inside macrophages by inhibiting the fusion of the phagosome with the lysosome, thus preventing bacterial degradation. This ability allows the bacteria to persist in a dormant state, which is the hallmark of latent tuberculosis. Modulation of immune responses. M. tuberculosis can also modulate the immune response by secreting proteins that interfere with the activity of immune cells. For example, the bacteria produce virulence factors like ESAT6 that impair immune cell activation and enhance survival inside host cells. Granuloma formation and maintenance. Granulomas, while important for containing the infection, can also provide a protected environment for the bacteria to survive in a dormant or slow-growing state. This allows M. tuberculosis to persist in the host for years without causing symptoms, leading to latent TB. Outcomes of immune response in tuberculosis, latent TB infection. In many cases, the immune system effectively controls the infection, and the bacteria remain contained within granulomas in a dormant state. This is known as latent tuberculosis (LTBI), and individuals may not show symptoms but can have a positive tuberculin skin test (TST) or interferon gamma release assay (IGRA). Latent TB can reactivate later in life if the immune system is weakened, e.g., due to HIV infection, malnutrition, or immunosuppressive drugs. Active TB disease. If the immune response is insufficient or fails to contain the bacteria, M. tuberculosis can proliferate, leading to active tuberculosis, characterized by symptoms such as persistent cough, fever, weight loss, and NETs. Active TB can spread to others through respiratory droplets. Caseous necrosis and tissue destruction in the lungs and other organs may occur due to prolonged inflammation. CSIR Net previous year questions. 1. CSIR Net June 2017, which of the following cytokines is primarily responsible for the activation of macrophages during mycobacterium tuberculosis infection? Immune response during bacterial infections, tuberculosis, CSIR Net JRF Life Sciences Lecture Introduction. Tuberculosis TB is a bacterial infection caused by Mycobacterium tuberculosis, primarily affecting the lungs but can also impact other parts of the body. The immune response to M. tuberculosis is complex and involves both innate and adaptive immunity. TB is a chronic infectious disease, and the immune system's ability to control or eliminate the bacteria determines the clinical outcome, ranging from asymptomatic infection, latent TB, to active disease. The immune response during tuberculosis infection can be divided into innate and adaptive immunity, both of which play crucial roles in controlling the infection. However, M. tuberculosis has evolved mechanisms to evade the immune system, contributing to chronic infection and the development of drug resistance. Innate immune response to tuberculosis, entry and recognition of pathogen. M. tuberculosis is primarily transmitted through respiratory droplets and is inhaled into the lungs, where it is engulfed by alveolar macrophages, the first line of defense. The bacteria are recognized by pattern recognition receptors, PRRs, such as toll-like receptors, TLRs, on the surface of macrophages. TLR2 and TLR4 are the most important receptors recognizing mycobacterial lipids and other components. Once internalized, M. tuberculosis can survive within macrophages by preventing the fusion of the phagosome, which contains the bacteria, with the lysosome, creating a favorable environment for its replication. Activation of the innate immune system. Upon recognition, macrophages secrete pro-inflammatory cytokines such as TNF-alpha, IL-1, and IL-12 that recruit other immune cells to the site of infection. Neutrophils are also recruited to the site of infection, but their role in tuberculosis is controversial. They contribute to the inflammatory response but are less effective at killing the bacteria compared to macrophages. Formation of the granuloma. A hallmark of the immune response to tuberculosis is the formation of a granuloma, a structure formed by macrophages, T lymphocytes, and other immune cells. The granuloma serves to contain the infection by walling off the bacteria. Caseous necrosis may occur in the center of the granuloma, which is often seen in active TB and indicates an area of tissue death due to persistent inflammation and bacterial persistence. Adaptive immune response to tuberculosis, T helper cell Th1 activation. The key adaptive immune response in tuberculosis is mediated by T lymphocytes, particularly CD4+ T cells. Upon activation, macrophages present mycobacterial antigens to naive T cells through MHC class II molecules. The interaction between antigen-presenting cells APCs and CD4+ T cells leads to the activation of a Th1 response, which is essential for the control of M. tuberculosis. Th1 cells secrete IFN gamma, a cytokine crucial for activating macrophages to kill the bacteria. Macrophage activation by IFN gamma. IFN gamma enhances the microbicidal activity of macrophages, promoting the production of reactive oxygen species ROS and nitric oxide NO to kill the bacteria. CD8+ cytotoxic T cells also play a role in killing infected cells directly by recognizing infected cells via MHC class I molecules. These cytotoxic T cells can target infected cells for apoptosis. Formation of a protective granuloma. The granuloma becomes a site of intense immune activity. CD4+ T cells, macrophages, and other immune cells form a structure, which serves to contain the bacteria and limit its spread. However, if the immune response is insufficient or dysregulated, the granuloma may not be able to effectively control the bacteria, leading to active TB. Immune evasion by mycobacterium tuberculosis, inhibition of phagosome-lysosome fusion. M. tuberculosis can survive inside macrophages by inhibiting the fusion of the phagosome with the lysosome, thus preventing bacterial degradation. This ability allows the bacteria to persist in a dormant state, which is the hallmark of latent tuberculosis. Modulation of immune responses. M. tuberculosis can also modulate the immune response by secreting proteins that interfere with the activity of immune cells. For example, the bacteria produce virulence factors like ESAT6 that impair immune cell activation and enhance survival inside host cells. Granuloma formation and maintenance. Granulomas, while important for containing the infection, can also provide a protected environment for the bacteria to survive in a dormant or slow-growing state. This allows M. tuberculosis to persist in the host for years without causing symptoms, leading to latent TB. Outcomes of immune response in tuberculosis, latent TB infection. In many cases, the immune system effectively controls the infection, and the bacteria remain contained within granulomas in a dormant state. This is known as latent tuberculosis (LTBI), and individuals may not show symptoms but can have a positive tuberculin skin test (TST) or interferon gamma release assay (IGRA). Latent TB can reactivate later in life if the immune system is weakened, e.g., due to HIV infection, malnutrition, or immunosuppressive drugs. Active TB disease. If the immune response is insufficient or fails to contain the bacteria, M. tuberculosis can proliferate, leading to active tuberculosis, characterized by symptoms such as persistent cough, fever, weight loss, and night sweats. Active TB can spread to others through respiratory droplets. Caseous necrosis and tissue destruction in the lungs and other organs may occur due to prolonged inflammation. CSIR-NET previous year questions. 1. CSIR-NET June 2017, which of the following cytokines is primarily responsible for the activation of macrophages during mycobacterium tuberculosis infection? A. IL-2B IL-4. CTNF alpha DIFN gamma answer, DIFN gamma. 2. CSIR-NET DEC 2019, the formation of granulomas in tuberculosis is primarily mediated by which of the following cells? A. B cells, BCD4+ T cells. C. Neutrophils, D natural killer cells answer, BCD4+ T cells. Conclusion. The immune response to mycobacterium tuberculosis involves both innate and adaptive mechanisms, with macrophages and T cells playing central roles. The Th1 response, particularly through IFN gamma production, is essential for controlling the infection and preventing the progression to active disease. However, M. tuberculosis has evolved several strategies to evade the immune system, leading to the persistence of the bacteria in a dormant state in many individuals. The balance between immune control and bacterial evasion is key to the outcome of TB infection, which can range from latent infection to active disease. Let me know if you need further details or have any additional queries. You said, parasitic malaria, ChatGPT said. Immune response during parasitic infections, malaria, CSIR-NET JRF Life Sciences Lecture Introduction. Malaria is a life-threatening parasitic disease caused by Plasmodium species, transmitted to humans through the bite of infected Anopheles mosquitoes. The immune response to Plasmodium infections is multifaceted, involving both the innate and adaptive immune systems. The immune response is crucial for controlling the parasite, but Plasmodium has developed mechanisms to evade the immune system, leading to persistent infections. Malaria remains a major global health challenge, particularly in tropical and subtropical regions. The clinical manifestations of malaria depend on the species of Plasmodium, the immune status of the host, and the effectiveness of the immune response. Innate immune response to malaria, initial recognition and response. Plasmodium enters the host through the bite of an infected Anopheles mosquito, and the sporozoites travel to the liver, where they invade hepatocytes and mature. The liver stage is typically asymptomatic, and the immune response is not yet fully activated. Once merozoites are released from liver cells into the bloodstream, they infect red blood cells, RBCs, causing the characteristic symptoms of malaria. This stage triggers a robust innate immune response. Pattern recognition receptors, PRRs. The innate immune system detects Plasmodium using pattern recognition receptors, PRRs, such as toll-like receptors, TLRs. TLRs on dendritic cells, macrophages, and neutrophils recognize Plasmodium components like merozoite surface proteins and glycosylphosphatidylinositol, GPI. Upon recognition, macrophages and dendritic cells produce pro-inflammatory cytokines such as TNF-alpha, IL-12, IL-6, and IFN-beta, which help recruit other immune cells to the site of infection. Neutrophils and natural killer NK cells. Neutrophils play a role in the initial defense against malaria but are less effective in directly killing Plasmodium parasites. NK cells are important in controlling the early stages of infection by producing IFN gamma, which activates macrophages and enhances their ability to kill the parasite. Complement system. The complement system is activated upon Plasmodium infection, leading to the lysis of infected red blood cells and enhanced opsonization of parasites, facilitating their recognition by phagocytes. Adaptive immune response to malaria, T cell mediated immunity. CD8+ T cells and CD4+ T cells are essential for the adaptive immune response to malaria. These cells are activated after recognition of Plasmodium antigens presented by MHC molecules on the surface of infected cells. CD4+ T cells are involved in orchestrating the immune response by secreting cytokines like IL-2, IFN gamma, and TNF-alpha, which help in the activation of macrophages and B cells. CD8+ T cells contribute to the control of the liver stage of the parasite by recognizing and killing infected hepatocytes. B cell mediated immunity. B cells produce antibodies against Plasmodium antigens such as the merozoite surface protein, MSP, and circumsporozoite protein, CSP. These antibodies help neutralize the parasite, prevent its entry into RBCs, and facilitate the clearance of Plasmodium through phagocytosis. IgM and IgG antibodies play significant roles in the immune response against malaria, and repeated exposure to the parasite can lead to the development of partial immunity in endemic areas. The production of antibodies is more efficient in individuals who have been exposed to malaria multiple times, which contributes to immunity in endemic regions. Immunological memory. After an initial infection, memory T cells and memory B cells are generated. These cells respond more efficiently to subsequent infections, providing partial immunity against Plasmodium. Immune evasion by Plasmodium, antigenic variation. Plasmodium can evade the immune system through antigenic variation, particularly in the surface proteins of the parasite, such as Plasmodium falciparum erythrocyte membrane protein 1 FEMP1. This protein is expressed on the surface of infected red blood cells and undergoes periodic changes, allowing the parasite to evade recognition by the immune system. Immune suppression. Plasmodium can modulate the host's immune response, leading to immune suppression. Infected individuals may have a reduced ability to mount a strong immune response, which allows the parasite to persist and replicate. Plasmodium has also been shown to affect the function of dendritic cells, macrophages, and T cells, impairing the initiation of adaptive immune responses. Immune tolerance. In regions where malaria is endemic, individuals who are repeatedly exposed to the parasite develop tolerance to certain Plasmodium antigens, which can result in the reduced effectiveness of the immune response in controlling the infection. Clinical outcomes of malaria and the immune response. Acute malaria. In acute malaria, the immune system mounts a strong response to the merozoite stage of the parasite, causing the symptoms of fever, chills, and anemia. If the immune response is not strong enough, Plasmodium can cause severe complications such as cerebral malaria, acute respiratory distress syndrome (ARDS), and organ failure. Chronic malaria and partial immunity. In areas where malaria is endemic, individuals who have been exposed to the parasite multiple times develop partial immunity. This immunity results in less severe disease upon subsequent infections, although individuals may still harbor low levels of parasites in their blood. Asymptomatic malaria. Malaria in immunocompromised individuals. In immunocompromised individuals, such as those with HIV/AIDS, pregnant women, or children under 5, the immune response is impaired, leading to a higher risk of severe malaria. These individuals may have a higher parasite load, and the infection may progress to life-threatening stages. CSIR-NET previous year questions. 1. CSIR-NET June 2018, which immune cells are primarily responsible for the destruction of Plasmodium-infected liver cells? A CD8 plus T cells, B CD4 plus T cells. C macrophages, D neutrophils. Answer: A CD8 plus T cells. 2. CSIR-NET DEC 2020, in malaria, the immune response against the parasite is predominantly mediated by which of the following types of antibodies? A IgG, B IgG. C IgM, D IgG. Answer: B IgG. Conclusion. The immune response to malaria involves a complex interplay of both innate and adaptive immune mechanisms. While the immune system can mount an effective defense against the parasite, Plasmodium has evolved multiple strategies to evade immune detection, including antigenic variation and immune suppression. In regions where malaria is endemic, repeated exposure leads to partial immunity, but the immune system's ability to clear the parasite is often limited. A better understanding of the immune response to malaria can help in the development of vaccines and therapeutic strategies to control and eliminate the disease. Let me know if you need any more details or further clarification. You said. Viral HIV infections, ChatGPT said. Immune response during viral infections, HIV, CSIR-NET JRF Life Sciences Lecture Introduction. HIV, human immunodeficiency virus, is a retrovirus that primarily targets and infects CD4 plus T cells, which play a critical role in the immune system's ability to fight infections. HIV leads to AIDS, acquired immunodeficiency syndrome, a condition characterized by progressive loss of immune function, making the body more susceptible to opportunistic infections and certain cancers. The immune response to HIV is complex, as the virus rapidly mutates and evades the immune system, which makes the development of an effective immune response challenging. Understanding the immune response to HIV infection is crucial for the development of vaccines and therapeutic strategies. Innate immune response to HIV, initial recognition and response. HIV enters the body through mucosal surfaces, typically during sexual contact or through contaminated blood products. The virus is initially recognized by the innate immune system. Dendritic cells at the mucosal surfaces capture HIV and transport it to lymph nodes, where the virus infects CD4 plus T cells. Pattern recognition receptors, PRRs. The innate immune response is mediated by pattern recognition receptors, PRRs, such as toll-like receptors, TLRs, which recognize viral RNA and glycoproteins on the surface of HIV. TLR3, TLR7, and TLR8 play a significant role in the early recognition of HIV in dendritic cells, leading to the activation of the type 1 interferon response, which has antiviral properties. Natural killer NK cells. NK cells are part of the early innate immune response to HIV. They recognize and kill infected cells, including those with reduced expression of MHC class I molecules, which is common in HIV-infected cells. However, HIV evades NK cells through the downregulation of MHCI molecules on infected cells, making them less susceptible to NK cell-mediated cytotoxicity. Macrophages and monocytes. Macrophages are another key part of the innate immune response. They phagocytose HIV particles in infected cells and produce pro-inflammatory cytokines like TNF-alpha, IL-1, and IL-6, which contribute to the inflammatory environment. Macrophages serve as long-lived reservoirs for the virus, allowing it to persist in tissues, particularly in the brain, gastrointestinal tract, and lymphoid organs. Adaptive immune response to HIV, T-cell-mediated immunity. CD4 plus T cells are the primary target of HIV infection. The virus binds to the CD4 receptor on the surface of these cells, along with a co-receptor CCR5 or CXCR4 facilitating viral entry. HIV causes the depletion of CD4 plus T cells, leading to progressive immunosuppression. The depletion is primarily due to direct viral cytotoxicity, CD8 plus T cell-mediated killing, and immune-mediated apoptosis. CD8 plus cytotoxic T lymphocytes, CTLs. CD8 plus T cells play a critical role in controlling HIV replication. They recognize and kill HIV-infected cells through MHCI presentation of viral peptides. The HIV-specific cytotoxic T lymphocyte, CTL, response is a key factor in controlling the virus during the early stages of infection. However, the virus rapidly mutates to evade the CTL response, leading to the eventual failure of this immune mechanism in chronic infection. B-cell-mediated immunity and antibodies. In the early stages of HIV infection, B cells produce anti-HIV antibodies, particularly IgM and IgG, which can neutralize the virus and prevent its spread. However, HIV's rapid mutation rate leads to the development of neutralizing antibody resistance and escape variants, making it difficult for the immune system to mount a sustained and effective antibody-mediated immune response. Broadly neutralizing antibodies, BNAbs, which can neutralize a wide range of HIV strains, have been identified in some individuals and are the subject of ongoing research. Immunological memory and viral escape. The immune system generates memory T cells and memory B cells that can respond to subsequent infections. However, HIV's ability to mutate rapidly and undergo antigenic variation makes it difficult for the immune system to develop long-lasting immunity. HIV latency also plays a key role in viral persistence. Infected cells can enter a latent state, where the virus remains dormant in the host genome, evading detection by the immune system. HIV immune evasion mechanisms, antigenic variation and mutation. One of the most critical strategies used by HIV to evade the immune response is its high mutation rate. The ENB gene, which encodes the GP120 surface glycoprotein, undergoes constant mutations, leading to the generation of viral escape variants that are resistant to the host's immune system. Antigenic variation in the virus allows it to evade recognition by both B cells and T cells. Latency and reservoir formation. HIV establishes a latent infection in CD4 plus T cells, macrophages, and other cells, particularly in lymphoid tissues in the brain. These latent reservoirs allow the virus to persist in the host, even in individuals on antiretroviral therapy (ART). HIV latency prevents the immune system from recognizing and eliminating infected cells, even during the chronic phase of infection. Immunosuppression. HIV directly induces the depletion of CD4 plus T cells, leading to immunosuppression. The loss of CD4 plus T cells results in a reduced capacity to mount adaptive immune responses against other pathogens, contributing to the development of opportunistic infections and AIDS. The virus also interferes with the function of macrophages, dendritic cells, and NK cells, impairing the ability of the immune system to recognize and eliminate infected cells. Clinical manifestations and immune response. Acute HIV infection. During the acute phase of infection, typically within 2 to 4 weeks of exposure, the body mounts a strong immune response. Viral load peaks, and CD4 plus T cell count drops temporarily. Individuals may experience flu-like symptoms, including fever, lymphadenopathy, and sore throat. During this phase, CTLs and antibodies play a role in controlling the infection, but the virus replicates rapidly, leading to high levels of viremia. Chronic HIV infection. The virus continues to replicate in the body, but immune control is not sufficient to eliminate the virus. CD4 plus T cells continue to decline over time, leading to an impaired immune response. Opportunistic infections become more common as immune function deteriorates, marking the transition to AIDS. AIDS. In the final stages of HIV infection, the immune system is severely compromised. The loss of CD4 plus T cells below 200 cells per cubic milliliter leaves the body vulnerable to a variety of infections, including pneumocystis jirovecii pneumonia, tuberculosis, and Kaposi sarcoma. CSIR-NET previous year questions. 1. CSIR-NET DEC 2018. Which of the following immune cells are primarily targeted by HIV? ACD8 plus T cells, BCD4 plus T cells. C. Macrophages, D. Dendritic cells. Answer: BCD4 plus T cells. 2. CSIR-NET June 2020. Which immune response is most important for controlling HIV infection during the acute phase? A. B cell mediated immunity, B. Antibody mediated immunity. CCD8 plus T cell mediated immunity, D. Macrophage mediated immunity. Answer: CCD8 plus T cell mediated immunity. Conclusion. The immune response to HIV infection involves complex interactions between innate and adaptive immune systems, but the virus's high mutation rate, latency, and immune evasion mechanisms make it difficult for the body to mount an effective defense. Antiretroviral therapy (ART) has been highly successful in controlling HIV replication, but there is still no cure. Ongoing research focuses on finding a functional cure, developing vaccines, and improving immune-based therapies to combat the virus effectively. Let me know if you need more details or any other clarification. You said. Congenital immunodeficiencies. ChatGPT said. Congenital immunodeficiencies. CSIR-NET JRF Life Sciences Lecture Introduction. Congenital immunodeficiencies, also known as primary immunodeficiencies (PIDs), are a group of disorders in which the immune system is intrinsically impaired due to genetic mutations. These conditions result in an increased susceptibility to infections, autoimmune diseases, and sometimes malignancies. The defects can affect various components of the immune system, including T cells, B cells, phagocytes, and complement proteins. Primary immunodeficiencies are classified based on the specific components of the immune system affected, and they can range from mild to life-threatening. Early diagnosis and treatment are crucial to managing these disorders, often involving immunoglobulin replacement, bone marrow transplants, or gene therapy. Types of congenital immunodeficiencies: B cell deficiencies, humoral immunodeficiency. X-linked agammaglobulinemia, Bruton's agammaglobulinemia. This is one of the most well-known B cell deficiencies, where patients have a defect in B cell development due to a mutation in the Bruton tyrosine kinase (BTK) gene. This results in an almost complete lack of immunoglobulins (Ig), leading to an inability to produce antibodies. Patients are highly susceptible to bacterial infections, especially from encapsulated organisms, e.g., Streptococcus pneumoniae. Clinical manifestations: recurrent bacterial infections, pneumonia, sinusitis, otitis media. Treatment: immunoglobulin replacement therapy and antibiotics. Common variable immunodeficiency (CVID). This condition is characterized by low levels of immunoglobulins IgG, IgA, and/or IgM, which results in defective antibody production. CVID can manifest at any age and leads to recurrent infections and an increased risk of autoimmune diseases and malignancies. Clinical manifestations: recurrent respiratory tract infections, gastrointestinal problems, autoimmune disorders. Treatment: immunoglobulin replacement therapy. T cell deficiencies, cellular immunodeficiency. Severe combined immunodeficiency (SCID). SCID is one of the most severe congenital immunodeficiencies, where both T cells and B cells are deficient due to mutations in genes responsible for lymphocyte development. The most common form is X-linked SCID, which is due to a defect in the IL-2 receptor gamma chain (IL-2RG) gene. This condition results in a severe defect in cell-mediated immunity and humoral immunity. Clinical manifestations: severe, life-threatening infections within the first few months of life, failure to thrive, chronic diarrhea. Treatment: hematopoietic stem cell transplantation, bone marrow transplant, gene therapy. DeGeorge syndrome, thymic hypoplasia. This condition is due to a deletion in chromosome 22q11.2, leading to thymic hypoplasia and hypocalcemia. The thymus, which is essential for T cell maturation, is underdeveloped, leading to T cell deficiency and an increased susceptibility to infections. Clinical manifestations: cardiac defects, hypoparathyroidism, facial dysmorphism, recurrent infections. Treatment: thymus transplant, calcium supplementation, antibiotics, and vaccines. Combined deficiencies: both T and B cell deficiency. Wiskott-Aldrich syndrome. This is an X-linked immunodeficiency caused by mutations in the WIS protein WASP gene. Was characterized by a combination of T cell dysfunction, B cell dysfunction, and platelet abnormalities. PADI. Cell-mediated congenital immunodeficiencies. CSIR-NET JRF Life Sciences Lecture Introduction. Congenital immunodeficiencies, also known as primary immunodeficiencies (PIDs), are a group of disorders in which the immune system is intrinsically impaired due to genetic mutations. These conditions result in an increased susceptibility to infections, autoimmune diseases, and sometimes malignancies. The defects can affect various components of the immune system, including T cells, B cells, phagocytes, and complement proteins. Primary immunodeficiencies are classified based on the specific components of the immune system affected, and they can range from mild to life-threatening. Early diagnosis and treatment are crucial to managing these disorders, often involving immunoglobulin replacement, bone marrow transplants, or gene therapy. Types of congenital immunodeficiencies: B cell deficiencies, humoral immunodeficiency. X-linked agammaglobulinemia, Bruton's agammaglobulinemia. This is one of the most well-known B cell deficiencies, where patients have a defect in B cell development due to a mutation in the Bruton tyrosine kinase (BTK) gene. This results in an almost complete lack of immunoglobulins (Ig), leading to an inability to produce antibodies. Patients are highly susceptible to bacterial infections, especially from encapsulated organisms, e.g., Streptococcus pneumoniae. Clinical manifestations: recurrent bacterial infections, pneumonia, sinusitis, otitis media. Treatment: immunoglobulin replacement therapy and antibiotics. Common variable immunodeficiency (CVID). This condition is characterized by low levels of immunoglobulins IgG, IgA, and/or IgM, which results in defective antibody production. CVID can manifest at any age and leads to resistance and an increased risk of autoimmune diseases and malignancies. Clinical manifestations: recurrent respiratory tract infections, gastrointestinal problems, autoimmune disorders. Treatment: immunoglobulin replacement therapy. T cell deficiencies, cellular immunodeficiency. Severe combined immunodeficiency. SCID is one of the most severe congenital immunodeficiencies, where both T cells and B cells are deficient due to mutations in genes responsible for lymphocyte development. The most common form is X-linked SCID, which is due to a defect in the IL-2 receptor gamma chain (IL-2RG) gene. This condition results in a severe defect in cell-mediated immunity and humoral immunity. Clinical manifestations: severe, life-threatening infections within the first few months of life, failure to thrive, chronic diarrhea. Treatment: hematopoietic stem cell transplantation, bone marrow transplant, gene therapy. DeGeorge syndrome, thymic hypoplasia. This condition is due to a deletion in chromosome 22q11.2, leading to thymic hypoplasia and hypocalcemia. The thymus, which is essential for T cell maturation, is underdeveloped, leading to T cell deficiency and an increased susceptibility to infections. Clinical manifestations: cardiac defects, hypoparathyroidism, facial dysmorphism, recurrent infections. Treatment: thymus transplant, calcium supplementation, antibiotics, and vaccines. Combined deficiencies: both T and B cell deficiency. Wiskott-Aldrich syndrome. Was this an X-linked immunodeficiency caused by mutations in the WIS protein WASP gene? Was this characterized by a combination of T cell dysfunction, B cell dysfunction, and platelet abnormalities? Patients often have eczema, thrombocytopenia, and recurrent infections. Clinical manifestations: eczema, thrombocytopenia, recurrent bacterial infections, autoimmune diseases, and malignancies. Treatment: hematopoietic stem cell transplantation, immunoglobulin replacement, and symptomatic treatment for bleeding and infections. Phagocytic deficiencies. Chronic granulomatous disease (CGD) is a disorder in which phagocytes, especially neutrophils and macrophages, cannot produce reactive oxygen species (ROS) to kill certain pathogens, leading to recurrent and severe infections. The defect is often caused by mutations in the NADPH oxidase complex, which is responsible for generating ROS. Clinical manifestations: recurrent bacterial and fungal infections, especially with catalase-positive organisms, e.g., Staphylococcus aureus, Aspergillus. Treatment: prophylactic antibiotics, interferon gamma therapy, and bone marrow transplantation. Leukocyte adhesion deficiency (LAD) is a disorder in which leukocytes, particularly neutrophils, are unable to adhere to endothelial cells due to mutations in the LFA1 integrin or CD18. This impairs the ability of neutrophils to migrate to sites of infection, leading to delayed wound healing and severe bacterial infections. Clinical manifestations: severe infections, delayed wound healing, and gingivitis. Treatment: bone marrow transplantation. Complement deficiencies. C3 deficiency. Complement component 3 C3 is a central component of the complement system, and its deficiency can lead to increased susceptibility to bacterial infections, particularly with encapsulated organisms like Streptococcus pneumoniae and Neisseria meningitidis. Clinical manifestations: recurrent bacterial infections, especially meningitis, pneumonia, and sepsis. Treatment: prophylactic antibiotics and, in some cases, complement component replacement therapy. Clinical manifestations of congenital immunodeficiencies. Recurrent infections. The hallmark feature of congenital immunodeficiencies is recurrent or unusual infections, which may involve bacteria, viruses, fungi, and parasites. Failure to thrive. Affected individuals may exhibit poor growth and development due to chronic infections or inadequate immune responses. Autoimmunity. Some congenital immunodeficiencies predispose individuals to develop autoimmune diseases due to dysregulated immune responses. Malignancies. Certain immunodeficiencies, particularly Wiskott-Aldrich syndrome and CVID, increase the risk of lymphomas and other cancers. Diagnosis of congenital immunodeficiencies. Family history. Many congenital immunodeficiencies have a hereditary pattern, e.g., X-linked, autosomal recessive, so family history of similar conditions is often helpful. Immunological testing. Tests include measuring levels of immunoglobulins, T cell counts, B cell counts, and complement activity. Specific genetic testing can identify mutations associated with known immunodeficiencies. Genetic analysis. Advanced techniques such as next-generation sequencing (NGS) are used to identify mutations in the genes associated with immune dysfunction. Flow cytometry, used to assess the function of immune cells, including T cells, B cells, and phagocytes. Treatment strategies. Immunoglobulin replacement therapy. This is a mainstay of treatment for humoral immunodeficiencies such as X-linked agammaglobulinemia and CVID. Regular infusions of IG provide passive immunity to prevent infections. Bone marrow transplantation. In conditions like SCID and Wiskott-Aldrich syndrome, hematopoietic stem cell transplantation (HSCT) can restore immune function by replacing the defective immune system with healthy cells. Gene therapy. Ongoing research is focused on using gene therapy to correct specific genetic defects, such as in SCID. Prophylactic antibiotics and antifungals. Regular use of antibiotics, antifungals, and antivirals may be necessary to prevent infections in patients with congenital immunodeficiencies. Management of complications. This includes bone marrow failure, autoimmunity, and malignancy in some conditions. CSIR-NET previous year questions. 1. CSIR-NET Deck 2016. Which of the following is a feature of X-linked agammaglobulinemia? A deficiency of T cell function, B lack of B cells. C decreased CD4 plus T cell count, D deficient neutrophil function. Answer: B lack of B cells. 2. CSIR-NET June 2019. Which of the following is the most common form of severe combined immunodeficiency SCID? Adenosine deaminase deficiency, BL2 receptor gamma chain deficiency. CRAG1 RAG2 mutation, DJAK3 mutation. Answer: BL2 receptor gamma chain deficiency. Conclusion. Congenital immunodeficiencies are a diverse group of disorders that result in a heightened vulnerability to infections and other immune-related complications. Early diagnosis and appropriate treatment, such as immunoglobulin replacement, bone marrow transplants, and gene therapy, are vital for improving the quality of life and survival of individuals with these conditions. Advances in genetic testing and immunotherapy continue to provide hope for better management and potential cures. Let me know if you need more information or further clarifications. You said. Acquired immunodeficiencies, ChatGPT said. Acquired immunodeficiencies, CSIR-NET JRF Life Sciences Lecture Introduction. Acquired immunodeficiencies are immunodeficiencies that develop due to external factors rather than genetic mutations. Unlike congenital primary immunodeficiencies, which are present at birth, acquired immunodeficiencies arise after birth due to factors like infections, medications, malnutrition, or cancers. The most well-known acquired immunodeficiency is HIV/AIDS, but other causes, such as malnutrition or the use of immunosuppressive drugs for transplant patients, can also impair immune function. Types of acquired immunodeficiencies. Human immunodeficiency virus, HIV, acquired immunodeficiency syndrome, AIDS. HIV is a retrovirus that specifically targets and destroys CD4 plus T cells, leading to progressive immunodeficiency. It is transmitted primarily through blood, semen, vaginal fluids, and breast milk. Pathophysiology. HIV integrates into the host genome, replicating within CD4 plus T cells, which are crucial for orchestrating immune responses. Over time, HIV leads to CD4 plus T cell depletion and immune dysregulation. This can result in opportunistic infections, e.g., tuberculosis, candidiasis, malignancies, e.g., Kaposi sarcoma, lymphomas, and neurological disorders. Clinical manifestations. Early signs include fever, fatigue, and weight loss. As the disease progresses, patients develop opportunistic infections, such as pneumocystis pneumonia, tuberculosis. Over time, HIV leads to CD4 plus T cell depletion and immune dysregulation. This can result in opportunistic infections, e.g., tuberculosis, candidiasis, malignancies, e.g., Kaposi sarcoma, lymphomas, and neurological disorders. Clinical manifestations. Early signs include fever, fatigue, and weight loss. As the disease progresses, patients develop opportunistic infections, such as pneumocystis pneumonia, tuberculosis, and cryptococcal meningitis. Diagnosis. Diagnosis is made through HIV antibody testing, ELISA or rapid test, followed by confirmatory Western blot or HIV RNA-PCR tests. The progression is monitored through the CD4 count and viral load. Treatment. Antiretroviral therapy, ART, is used to suppress HIV replication and maintain immune function. ART has significantly improved the life expectancy and quality of life for HIV-infected individuals. Immunosuppressive therapy-induced immunodeficiency. Immunosuppressive drugs, e.g., corticosteroids, calcineurin inhibitors, methotrexate, azathioprine, are used in various clinical settings, particularly for organ transplantation and the treatment of autoimmune diseases. These drugs impair the function of T cells, B cells, and other immune components. Clinical manifestations. Patients on immunosuppressive therapy are at increased risk for opportunistic infections, e.g., fungal infections, tuberculosis, cytomegalovirus cancers, and wound infections. Management. Reduction of immunosuppressive therapy and prophylactic use of antifungal, antiviral, and antibacterial drugs. Cancer-induced immunodeficiency. Malignancies, particularly those affecting the bone marrow or lymphoid organs, can lead to acquired immunodeficiencies. Leukemia, lymphoma, and myeloma can disrupt the normal development and function of immune cells. Clinical manifestations. Anemia, leukopenia, thrombocytopenia, and increased susceptibility to infections. Lymphoma and leukemia are associated with increased risk of both bacterial and viral infections. Treatment. Immunotherapy, e.g., monoclonal antibodies, chemotherapy, and bone marrow or stem cell transplants. Malnutrition-induced immunodeficiency. Severe malnutrition, particularly the deficiency of essential nutrients like protein, vitamins, and minerals, can impair the function of both T cells and B cells. Clinical manifestations. Protein energy malnutrition leads to immunosuppression, with increased susceptibility to infections and delayed wound healing. Management. Nutritional support, including protein-rich foods and micronutrient supplementation, e.g., vitamin A, zinc, iron. Age-related immunodeficiency, immunosenescence. Immunosenescence refers to the gradual decline in immune function with age, particularly affecting the T-cell-mediated immune response. Older individuals have a reduced ability to mount effective responses to infections and vaccines. Clinical manifestations. Increased susceptibility to infections, particularly pneumonia, urinary tract infections, and shingles due to reactivation of the varicella-zoster virus. Management. Vaccination, e.g., pneumococcal and influenza vaccines, and adjuvanted vaccines are important for improving immune responses in the elderly. Clinical features of acquired immunodeficiencies. Increased susceptibility to infections. Individuals with acquired immunodeficiencies are prone to recurrent or unusual infections, particularly opportunistic infections. These infections are caused by pathogens that normally do not pose a threat to healthy individuals but exploit weakened immune systems. Autoimmune disorders. In certain cases, acquired immunodeficiencies can lead to autoimmunity. The suppressed immune system can sometimes result in immune dysregulation, leading to autoimmune diseases like rheumatoid arthritis, lupus, and autoimmune thyroid disorders. Failure to respond to vaccination. Acquired immunodeficiencies impair the ability to respond to vaccinations, leading to inadequate protection against preventable diseases, e.g., influenza, pneumococcal infections. Cancer. Immunodeficient individuals, particularly those with HIV, AIDS, or those on immunosuppressive therapy, are at higher risk for developing cancers, especially Kaposi sarcoma, lymphomas, and skin cancers. Diagnosis of acquired immunodeficiencies. Clinical history. A detailed history of infections, medications, immunosuppressive drugs, and underlying conditions like HIV or cancer is crucial for diagnosis. Laboratory tests. CD4 plus T cell count for HIV. Viral load testing for HIV. Immunoglobulin levels, IgG, IgM, IgA. Complete blood count, CBC, for detecting leukopenia or thrombocytopenia. Flow cytometry to evaluate T cell, B cell, and NK cell function. Genetic testing. In cases where the acquired immunodeficiency is associated with a genetic predisposition, e.g., cancer or inherited predisposition to infections. Management of acquired immunodeficiencies. Antiretroviral therapy, ART, for HIV/AIDS. ART is a cornerstone of treatment. It works by inhibiting viral replication and restoring immune function. Immunosuppressive drug management. Reducing the dose or switching to less immunosuppressive agents may be necessary for patients with organ transplant complications or autoimmune diseases. Prophylaxis for opportunistic infections. Prophylactic antibiotics, antivirals, and antifungals may be prescribed for patients at high risk of opportunistic infections, e.g., pneumocystis pneumonia in HIV patients. Vaccination. Timely vaccinations, including those against influenza, pneumococcus, and hepatitis, are important for individuals with acquired immunodeficiencies, particularly the elderly or those with immunosuppressive therapy. Nutritional support. Malnutrition-induced immunodeficiencies are treated with nutritional supplementation, focusing on essential proteins and micronutrients. Stem cell transplant. In cases of leukemia or lymphoma, hematopoietic stem cell transplantation (HSCT) may be used to restore immune function. CSIR-NET previous year questions. 1. CSIR-NET Deck 2017. Which of the following is a major cause of acquired immunodeficiency? A. Genetic mutations. B. Viral infections like HIV. C. Autoimmune diseases. D. All of the above. Answer. B. Viral infections like HIV. 2. CSIR-NET June 2019. Which of the following is a characteristic feature of HIV infection? A. Increased CD4 plus T cell count. B. Decreased CD4 plus T cell count. C. Increased IgG levels. D. None of the above. Answer. B. Decreased CD4 plus T cell count. Conclusion. Acquired immunodeficiencies result from external factors such as HIV infection, cancer, immunosuppressive therapy, or malnutrition. Management of these conditions involves targeted therapies, prophylactic treatments, and, in some cases, stem cell transplants. Early diagnosis and appropriate interventions are critical in improving outcomes and reducing the impact of infections and complications in immunocompromised individuals. Let me know if you need further details or clarification. You said. Paragraph type of answers from now on. Okay, don't waste space. Full capacity. ChatGPT said. Updated saved memory. Understood. I'll provide detailed, paragraph-based answers from now on, ensuring maximum capacity and no wasted space. Let me know if you need anything else. You said. Developmental biology. A. Basic concepts of development. ChatGPT said. Developmental biology. Basic concepts of development. Developmental biology is the branch of biology that studies the process by which organisms grow and develop. It encompasses a wide range of processes, from fertilization to the final form and function of the organism. The basic concepts of development include embryogenesis, cell differentiation, morphogenesis, and growth, all of which contribute to the transformation of a single fertilized egg into a complex, multicellular organism. Embryogenesis refers to the early stages of development that occur after fertilization, leading to the formation of the embryo. This process includes the division of the zygote fertilized egg, its differentiation into specialized cell types, and the patterning of these cells into tissues and organs. Cleavage, the rapid division of the fertilized egg, is the first stage of embryogenesis and leads to the formation of a multicellular structure known as the blastula. Following this, the process of gastrulation occurs, where the blastula reorganizes into three distinct germ layers: ectoderm, mesoderm, and endoderm, each of which will give rise to different tissues and organs in the mature organism. Cell differentiation is the process by which unspecialized cells become specialized to perform specific functions. Initially, cells of the embryo are totipotent, meaning they can develop into any cell type. As development progresses, these cells become progressively restricted in their potential, a process driven by genetic and environmental signals. The control of gene expression plays a key role in this specialization. For instance, during neurulation, cells of the ectoderm differentiate to form the neural tube, which will later give rise to the nervous system. Morphogenesis involves the process by which cells and tissues acquire their proper size, shape, and position in the developing organism. This is governed by complex interactions between signaling pathways, mechanical forces, and cell behaviors like cell migration and apoptosis, programmed cell death. These processes ensure the correct formation of structures such as limbs, the heart, and other organs. Morphogenic movements include processes such as invagination, the inward folding of cells, convergent extension, the narrowing and elongation of a tissue, and epithelial to mesenchymal transition (EMT), which is essential in the development of structures like the neural crest. Finally, growth refers to the increase in size of the organism or its parts through the division and enlargement of cells. Growth is influenced by factors such as hormones, nutrient availability, and genetic programming. The balance between cell proliferation, division, and cell death is crucial in shaping the overall size and proportion of the organism. Together, these processes, embryogenesis, cell differentiation, morphogenesis, and growth, provide the foundation for the complex, highly regulated development of multicellular organisms. Understanding these processes is critical not only in basic biology but also in applied fields such as regenerative medicine, stem cell therapy, and cancer biology, where abnormal development can lead to diseases. You said, potency, ChatGPT said. Potency in developmental biology. Potency refers to the capacity of a cell to differentiate into various cell types, and it is a crucial concept in developmental biology, particularly in understanding the potential of stem cells during embryogenesis. Potency defines the range of cell fates a given cell can acquire during development and is often categorized based on the degree of differentiation potential of a cell. The more potent a cell is, the broader its ability to differentiate into various cell types. The concept of potency is usually described in terms of totipotency, pluripotency, multipotency, and unipotency, each reflecting a cell's ability to give rise to different types of cells. Totipotency, a totipotent cell is the most potent type of cell. It has the potential to give rise to all cell types within the organism, including both the embryonic and extraembryonic tissues. The fertilized egg zygote is a classic example of a totipotent cell. After fertilization, the zygote divides, and its daughter cells remain totipotent until they begin to specialize into specific cell types during development. The ability to generate the entire organism, including the placental tissue, is what characterizes totipotency. Pluripotency. Pluripotent cells are capable of giving rise to all embryonic cell types, but they cannot form extraembryonic tissues like the placenta. The inner cell mass of the blastocyst is made up of pluripotent cells, which can differentiate into the three germ layers, ectoderm, mesoderm, and endoderm, that give rise to all body tissues and organs. Embryonic stem cells, ESCs, are considered pluripotent because they have the potential to develop into any cell type within the body, excluding the placenta. Multipotency. Multipotent cells have a more restricted capacity for differentiation compared to pluripotent cells. They can give rise to a limited number of related cell types, typically within a specific. Pluripotency. Pluripotent cells are capable of giving rise to all embryonic cell types, but they cannot form extraembryonic tissues like the placenta. The inner cell mass of the blastocyst is made up of pluripotent cells, which can differentiate into the three germ layers, ectoderm, mesoderm, and endoderm, that give rise to all body tissues and organs. Embryonic stem cells, ESCs, are considered pluripotent because they have the potential to develop into any cell type within the body, excluding the placenta. Multipotency. Multipotent cells have a more restricted capacity for differentiation compared to pluripotent cells. They can give rise to a limited number of related cell types, typically within a specific tissue or organ. Adult stem cells, such as hematopoietic stem cells, HSCs, are examples of multipotent cells. HSCs can differentiate into various types of blood cells, red blood cells, white blood cells, platelets, but cannot produce cells of other tissues such as neurons or muscle cells. Unipotency. Unipotent cells have the least potency. They are capable of differentiating into only one type of cell. These cells are highly specialized and typically have a single function. For example, skin cells or muscle cells can be considered unipotent because, under normal conditions, they can only give rise to other cells of their own type. Multipotency. Multipotent cells have a more restricted capacity for differentiation compared to pluripotent cells. They can give rise to a limited number of related cell types, typically within a specific tissue or organ. Adult stem cells, such as hematopoietic stem cells, HSCs, are examples of multipotent cells. HSCs can differentiate into various types of blood cells, red blood cells, white blood cells, platelets, but cannot produce cells of other tissues such as neurons or muscle cells. Unipotency. Unipotent cells have the least potency. They are capable of differentiating into only one type of cell. These cells are highly specialized and typically have a single function. For example, skin cells or muscle cells can be considered unipotent because, under normal conditions, they can only give rise to other cells of their own type, such as keratinocytes in the case of skin cells. The concept of potency is essential for understanding stem cell biology, tissue regeneration, and developmental processes. Potency is also integral to stem cell therapies, where the potential to manipulate cell fate and reprogram cells into different types can offer revolutionary possibilities for treating degenerative diseases and injuries. Moreover, the loss of potency or incorrect differentiation of cells can lead to developmental disorders and diseases such as cancer, where stem cells may become abnormally potent and uncontrollably proliferate. You said. Hello, I want CSIR Net JRF Life Science Lectures JRF level, very high quality. Topic: Gene regulation in prokaryotes and eukaryotes. Gene regulation is the process by which cells control the expression of their genes. It is essential for maintaining cellular functions and responding to environmental changes. Gene regulation in prokaryotes and eukaryotes occurs through complex mechanisms that are finely tuned to ensure appropriate gene expression for different developmental stages and environmental conditions. Gene regulation in prokaryotes. In prokaryotes, gene regulation primarily involves controlling the transcription process. The most well-known system of gene regulation is the lac operon in Escherichia coli. The lac operon is a classic example of an inducible system where the presence of lactose induces the expression of genes required for its metabolism. The operon model, first proposed by François Jacob and Jacques Monod, consists of a promoter, an operator, and a set of structural genes. The lac repressor protein binds to the operator region in the absence of lactose, preventing RNA polymerase from transcribing the genes. When lactose is present, it binds to the repressor, causing a conformational change that releases the repressor from the operator, allowing transcription to occur. This mechanism ensures that the genes for lactose metabolism are only expressed when needed, conserving energy and resources. Another significant regulatory mechanism in prokaryotes is attenuation, observed in the tryptophan operon in E. coli. Attenuation involves the formation of different mRNA structures depending on the availability of tryptophan, allowing premature termination of transcription when tryptophan is abundant. Gene regulation in eukaryotes. Gene regulation in eukaryotes is far more complex, given the higher degree of cellular specialization and the presence of various regulatory factors. Eukaryotic gene regulation occurs at several levels: chromatin remodeling, transcription initiation, RNA processing, translation, and post-translational modifications. One of the key features of eukaryotic gene regulation is chromatin remodeling, which controls access to DNA for transcription. The chromatin structure consists of DNA wrapped around histone proteins, forming nucleosomes. The degree of compaction of chromatin influences gene expression, with euchromatin being loosely packed and transcriptionally active, while heterochromatin is tightly packed and transcriptionally silent. Histone modifications, such as acetylation, methylation, and phosphorylation, play a crucial role in regulating chromatin structure and gene expression. For example, acetylation of histones neutralizes their positive charge, loosening the chromatin and allowing transcription factors and RNA polymerase to access the DNA. Transcription factors are critical in eukaryotic gene regulation. These proteins bind to specific DNA sequences in the promoter and enhancer regions of genes to activate or repress transcription. Transcription factors such as activators, repressors, and co-activators work together to modulate gene expression. Enhancers are regulatory DNA elements that can be located far from the gene they regulate, and they interact with the promoter through the formation of a DNA loop. Silencers, on the other hand, repress transcription by binding to specific repressor proteins. One well-known example of transcription factor regulation is the p53 protein, which is involved in regulating the cell cycle and apoptosis. Mutations in p53 can lead to uncontrolled cell division, contributing to cancer. RNA processing is another level of gene regulation in eukaryotes. After transcription, the primary RNA transcript undergoes splicing, 5' capping, and 3' polyadenylation. The removal of introns and the joining of exons in RNA splicing allow the formation of mature mRNA, which is then transported to the cytoplasm for translation. Alternative splicing enables a single gene to produce multiple protein isoforms, increasing the diversity of the proteome. Post-translational regulation also plays a significant role in gene expression. Proteins can undergo modifications such as phosphorylation, acetylation, ubiquitination, and methylation, which can alter their function, stability, or localization. For example, ubiquitination marks proteins for degradation by the proteasome, regulating their levels within the cell. Key concepts. Operon model in prokaryotes. Gene expression is regulated through the operon system, such as the lac operon. Chromatin remodeling in eukaryotes. Topic: Gene regulation in prokaryotes and eukaryotes. Gene regulation is the process by which cells control the expression of their genes. It is essential for maintaining cellular functions and responding to environmental changes. Gene regulation in prokaryotes and eukaryotes occurs through complex mechanisms that are finely tuned to ensure appropriate gene expression for different developmental stages and environmental conditions. Gene regulation in prokaryotes. In prokaryotes, gene regulation primarily involves controlling the transcription process. The most well-known system of gene regulation is the lac operon in Escherichia coli. The lac operon is a classic example of an inducible system where the presence of lactose induces the expression of genes required for its metabolism. The operon model, first proposed by François Jacob and Jacques Monod, consists of a promoter, an operator, and a set of structural genes. The lac repressor protein binds to the operator region in the absence of lactose, preventing RNA polymerase from transcribing the genes. When lactose is present, it binds to the repressor, causing a conformational change that releases the repressor from the operator, allowing transcription to occur. This mechanism ensures that the genes for lactose metabolism are only expressed when needed, conserving energy and resources. Another significant regulatory mechanism in prokaryotes is attenuation, observed in the tryptophan operon in E. coli. Attenuation involves the formation of different mRNA structures depending on the availability of tryptophan, allowing premature termination of transcription when tryptophan is abundant. Gene regulation in eukaryotes. Gene regulation in eukaryotes is far more complex, given the higher degree of cellular specialization and the presence of various regulatory factors. Eukaryotic gene regulation occurs at several levels: chromatin remodeling, transcription initiation, RNA processing, translation, and post-translational modifications. One of the key features of eukaryotic gene regulation is chromatin remodeling, which controls access to DNA for transcription. The chromatin structure consists of DNA wrapped around histone proteins, forming nucleosomes. The degree of compaction of chromatin influences gene expression, with euchromatin being loosely packed and transcriptionally active, while heterochromatin is tightly packed and transcriptionally silent. Histone modifications, such as acetylation, methylation, and phosphorylation, play a crucial role in regulating chromatin structure and gene expression. For example, acetylation of histones neutralizes their positive charge, loosening the chromatin and allowing transcription factors and RNA polymerase to access the DNA. Transcription factors are critical in eukaryotic gene regulation. These proteins bind to specific DNA sequences in the promoter and enhancer regions of genes to activate or repress transcription. Transcription factors such as activators, repressors, and co-activators work together to modulate gene expression. Enhancers are regulatory DNA elements that can be located far from the gene they regulate, and they interact with the promoter through the formation of a DNA loop. Silencers, on the other hand, repress transcription by binding to specific repressor proteins. One well-known example of transcription factor regulation is the p53 protein, which is involved in regulating the cell cycle and apoptosis. Mutations in p53 can lead to uncontrolled cell division, contributing to cancer. RNA processing is another level of gene regulation in eukaryotes. After transcription, the primary RNA transcript undergoes splicing, 5' capping, and 3' polyadenylation. The removal of introns and the joining of exons in RNA splicing allow the formation of mature mRNA, which is then transported to the cytoplasm for translation. Alternative splicing enables a single gene to produce multiple protein isoforms, increasing the diversity of the proteome. Post-translational regulation also plays a significant role in gene expression. Proteins can undergo modifications such as phosphorylation, acetylation, ubiquitination, and methylation, which can alter their function, stability, or localization. For example, ubiquitination marks proteins for degradation by the proteasome, regulating their levels within the cell. Key concepts. Operon model in prokaryotes. Gene expression is regulated through the operon system, such as the lac operon. Chromatin remodeling in eukaryotes. Histone modifications, DNA methylation, and chromatin structure control gene accessibility. Transcription factors and enhancers, key regulators of gene expression in eukaryotic cells. RNA processing and alternative splicing allows for regulation at the post-transcriptional level. Post-translational modifications, critical in regulating protein function and stability. Previous year questions. CSIR-NET JRF 2017. Which of the following is a correct mechanism of gene regulation in prokaryotes? A. Regulation of transcription by repressors and activators. B. Control of gene expression by chromatin remodeling. C. Regulation of gene expression by alternative splicing. D. Gene expression regulation through RNA interference. Answer. A. Regulation of transcription by repressors and activators. CSIR-NET JRF 2018. In eukaryotes, the activation of transcription is most often mediated by the binding of a. Repressor proteins to promoter regions. B. Histone deacetylase complexes. C. Transcription factors to enhancer regions. D. DNA methyltransferases to the promoter region. Answer. C. Transcription factors to enhancer regions. CSIR-NET JRF 2016. Which of the following best describes the role of histone acetylation in gene regulation? A. It leads to the formation of heterochromatin. B. It increases the transcriptional activity of the gene. C. It represses gene expression by making the chromatin more compact. D. It silences gene expression through DNA methylation. Answer. B. It increases the transcriptional activity of the gene. These questions test your understanding of both prokaryotic and eukaryotic gene regulation mechanisms, including the roles of transcription factors, chromatin remodeling, and operon systems in controlling gene expression. The complexity of gene regulation in eukaryotes, involving multiple layers of control such as chromatin structure, transcription factors, and post-translational modifications, is often a focus in CSIR-NET life sciences exams. Therefore, mastering these concepts is crucial for exam success. You said, potency, ChatGPT said. Potency in developmental biology. Potency refers to the capacity of a cell to differentiate into various cell types, and it plays a crucial role in developmental biology, particularly in understanding the potential of stem cells during development. The potency of a cell defines the range of cell fates it can acquire, and it is classified based on the degree of differentiation potential of a cell. Cells can be totipotent, pluripotent, multipotent, or unipotent, each category reflecting a progressively narrower ability to differentiate into different cell types. Totipotency is the highest form of potency. A totipotent cell has the potential to give rise to all the cell types in the body, as well as extraembryonic tissues such as the placenta. The zygote, which is the fertilized egg, is a classic example of a totipotent cell. As the zygote divides, its daughter cells remain totipotent for a brief period before they begin to specialize. In some animals, such as humans, the first few divisions of the zygote produce cells that can form any part of the embryo or the supporting structures, like the placenta. This extreme developmental potential makes totipotent cells fundamental in the early stages of embryogenesis. Pluripotency, on the other hand, refers to the ability of a cell to differentiate into any cell type of the three germ layers, ectoderm, mesoderm, and endoderm. However, pluripotent cells cannot form extraembryonic tissues like the placenta. Pluripotent stem cells, such as those found in the inner cell mass of the blastocyst, can differentiate into any cell type within the organism, making them crucial in early development. Embryonic stem cells (ESCs) derived from the inner cell mass of the blastocyst are examples of pluripotent cells that can be cultured in vitro and used for therapeutic purposes like regenerative medicine. Multipotency is more restricted than pluripotency. Multipotent cells can give rise to multiple, but limited, cell types, typically those of a specific tissue or organ. These cells are found in adult tissues and are responsible for maintaining and repairing those tissues. A well-known example is the hematopoietic stem cells (HSCs), which are found in the bone marrow and can differentiate into various types of blood cells, such as erythrocytes, leukocytes, and platelets. Although multipotent cells have more limited differentiation potential than pluripotent cells, they are critical for tissue homeostasis and repair. Unipotency represents the lowest level of potency. Unipotent cells can only differentiate into one specific cell type. They are highly specialized, and while they do not have the versatility of pluripotent or multipotent cells, they are essential for tissue maintenance. An example of unipotent cells is the muscle stem cells, satellite cells, that generate muscle cells, myocytes throughout an organism's life. The concept of potency is fundamental in understanding stem cell biology, tissue regeneration, and developmental processes. Potent cells, particularly totipotent and pluripotent stem cells, are of great interest in regenerative medicine and stem cell therapy. They hold the potential to regenerate damaged tissues or even generate entire organs. However, the ability to control the differentiation of these cells is crucial to ensure that they do not lead to uncontrolled growth, as seen in cancer, or produce the wrong types of cells. In summary, potency describes the differentiation potential of cells, ranging from the broad potential of totipotent cells through the more